Namaskar. You are watching Dr. KK Med Talks Fridays with Dr. Anita Khan, non-stop show 946 episode. Let's have the headlines of the day. Systemic inequities are putting women's health and lives at risk, Heart and Stroke report. According to a recent study, long COVID can affect heart rate variability. A Topsy study provides new insights into yellow fever's impact on heart. Recent survey has revealed that women less likely to be given CPR than men in public places by bystanders. Two automated external defibrillator machines have been installed at Lok Bhavan in Lucknow to help handle cardiac arrest cases. Let's go to the topic of the day. Now, we will be talking about cardiac arrest in women. Suddenly राह चलते किसी भी व्यक्ति को एकदम कार्डियक अरेस्ट हो सकता है और विमेन में ये थोड़ा सा ज़्यादा पोटेंशियली डेंजरस होता है। जैसे कि अभी न्यूज़ में बताया कि कई लोग फीमेल्स को रिवाइव करने से घबराते हैं। तो आज इसके बारे में बात करने के लिए हमारे पास आए हैं डॉक्टर केशव मूर्ति सीबी. He is a distinguished medical professional with extensive qualifications in the field of cardiology. Dr. Murthy holds an MBBS and MD in general medicine along with an advanced degree in DM and DNB in cardiology. With over 24 years experience in interventional cardiology, he is trailblazer in the field, boasting numerous firsts. A sought after national and international cardiology speaker, he serves as the principal investigator in clinical trials, a consultant editor, and a past president of the Cardiology Society, Mysore chapter. His remarkable career includes over 25,000 coronary angiograms and 5,000 angioplasties, solidifying his status as an eminent interventional cardiologist. Dr. Keshavmurthy is dedicated to providing compassionate and comprehensive healthcare services, making significant contributions to the well-being of patients in the Mysore region. Although he very casually said, just introduce me as interventional cardiologist from Mysore, but I think मुझे सुनने वालों को बताना चाहिए. So today we will be talking about cardiac arrest in women. So shall we start, sir?
Sure. Thank you for the very kind introduction. I don't think I deserve so much of accolades. I'm just a simple interventional cardiologist and trying to do my best for my patients. Yeah.
So what are the common misconceptions surrounding cardiac arrest in women?
Yeah, very current and interesting. And today's topic you have chosen for discussion. There are several misconceptions about cardiac diseases in general and also cardiac arrest in women. I would say we all believe just even as recently as a decade that women don't have so many heart attacks as men. They have less heart attacks. They are prone for heart diseases and all. But you would be surprised to know if I ask the question, what is the commonest number one killer disease in women? You will all think of women related diseases like cervical cancer or breast cancer or uterine cancer or pregnancy, some diseases like that. But if you put all the five cancers in women together, still the death due to heart disease exceeds that. This is one common and very common misconception in the general public. And also, surprisingly, even among doctors, when they were surveyed, they said women are less prone to heart attacks, and that belief persisted. But of late, in the past decade, especially with several talks and webinars, and that demand for equality has been there, and that has kind of turned the things around. And now, when a patient sits in front of us, woman or man, and there is no discrimination, we apply the same kind of diagnostic modalities and provide them with an equal kind of attention and treatment, which has improved the outcomes.
So how does cardiac arrest in women differ from that in men? in both in terms of symptoms and the risk factors.
Yeah. Women and men have the common normal, so-called normal risk factors, which we think of as hypertension, diabetes, dyslipidemia, high cholesterol levels. All these are common amongst both men and women. But up to the age of 45, up to the age of menopause, women are protected by the protective hormones, the estrogen, especially, which has beneficial effect on the endothelium, thereby reducing the risk of vascular diseases up to that age. But once that passes and a decade passes after that, the incidence of heart disease becomes equal in men and women, which is a point which we frequently ignore and continue to look at women as low risk. It is not. And also, there are certain factors in premenopausal women. If we see the last 5 years data, heart diseases between the age of 35 and 47 has been steadily increasing because of various factors, the regional factors, maybe the peculiar or unusual things like smoking in women. You would be surprised to know that worldwide there is a decline in smoking trend, especially because of government regulations or people awareness, or in Europe, US, and all that. There is a decreasing trend in tobacco consumption, especially smoking. Whereas in India, in the 11 to 20 age group, the teenage and the college going population, smoking is increasing. And also, the most surprising factor is smoking is increasing in women in this age group, which is most shocking. We would think culturally we are a country more conservative, and our especially women don't smoke, especially in public and things like that, which is a kind of a serious misconception. There is a progressive increase which is worsening heart disease. The other important factor that I would mention is if we see the younger women with heart disease or heart attacks or strokes, they almost always have diabetes as a risk factor. This is one ignored segment. If a woman below 40 presents with a heart attack, invariably she is diabetic. If she is not diabetic or dyslipidemic or has family history, we seriously look at other factors like arthritis or spontaneous coronary artery dissection or any of the thrombotic, prothrombotic disorders.
Right. So, are there any specific warning signs of cardiac arrest that women should be aware of?
Absolutely. One of the important distinctions in men and women is that men, as soon as they get their symptoms, they go to a heart specialist or even their GP and tell their symptoms straight. Whereas what studies have shown that in women, they do not have classical symptoms of chest pain. They have atypical symptoms, like, for example, extreme tiredness or giddiness or a syncope or a backache or a shoulder pain or an arm pain or jaw pain. These are all atypical symptoms. These classically, when you go to your general practitioner or a doctor, if you complain of a backache in the mid back, nobody will take an ECG or investigate you for heart disease. So, especially in women, they present late. They ignore their symptoms for the well-being of the family, which they sacrifice. They don't find time in their work. They spend most of their time taking care of the family and other family members and children, especially. So they ignore their own symptoms and present late. So some of the warning symptoms may be missed, and when they present late, it may be difficult to treat them, and they may present with a cardiac arrest rather than the cardiac symptoms, which would make it easier. And also, like you rightly pointed out in the news item itself, when especially in the public places, women develop a cardiac arrest, there is a significant reluctance by the bystander to do CPR and give them attention because of various fears. Of course, as medical personnel, we can overcome them, but in the public, touching a woman, a stranger woman in public is no, especially in our culture. And this, surprisingly, when I was reading for this some information for this talk, I realized that they don't receive as much cardiopulmonary resuscitation as a man would have in a similar situation, which I think should be overcome. And with more education, more public education, a cardiac arrest is a cardiac arrest. A human life is a human life. It is not distinguished by gender in any manner.
I agree with you totally. So, how does stress impact the cardiovascular health of women and contribute to the risk of cardiac arrest?
Oh, it's an absolutely important point. In the modern era, when we see with the competitive lifestyle, the comparative kind of lifestyle, stress has become an extremely important factor for causing vascular disease, heart attacks, and strokes. We see many patients in their 30s and 40s, many times working in they say IT industry is more prone because they are sedentary and work with kind of timelines and they set their dates and things like that. But also, other than the IT factors, also there is a tremendous amount of stress in the modern lifestyle, which women tend to take it upon themselves. And when we find that they do not have the conventional risk factors like hypertension or diabetes or high lipid levels, stroke seems to be an important, a very important factor causing heart attacks as an isolated risk factor. And many a time we tell women and ask, nowadays we are more conscious about asking about these factors, whether you are stressed at home due to any reason, especially when we find that they are presented with high blood pressure, high heart rates. We specifically question them and try to find out, though many women are reticent to share their problems about their familial stress. When you particularly question, they do give a kind of a non-verbal communication, and from there on we can guess that and try to address that as a primary risk factor for heart disease.
Right, right. So, another thing that you can tell our listeners today is, our viewers, are there any preventive measures or lifestyle changes that can significantly reduce the risk of cardiac arrest in women? Like you said, smoking.
Absolutely. The most important thing in heart disease is about 60% to 70% of heart attacks are preventable. That is the saddest thing that is happening. There's not much attention being given to the preventable aspect of coronary artery disease, though it is a non-communicable disease. We know that there are several national programs for, say, tuberculosis or leprosy or nutritional programs and all that. But in this era, in this decade, and particularly in the next decade, we have to definitely give more attention to prevention of cardiovascular disease. In fact, cardiovascular disease is the number one killer in India, and we contribute about 60% to the world's vascular disease burden, which is again a big number for India. So prevention is an extremely important factor. I would stress on that because prevention is better than cure, like the old adage goes. And when we talk of prevention, it's all about diet, lifestyle. We know that hypertension, diabetes, obesity, the obesity epidemic or the diabetes epidemic are all related to lifestyle. So we call this group of disorders as lifestyle disorders. So by a simple change in lifestyle, by adopting better dietary practices, by being less sedentary, by being more active, by doing some kind of physical exercise every single day, by modifying our food habits, reducing the saturated fats and sugars in our diet, for example, for us, not only for us, for our family members, for our loved ones, for our children. I would emphasize here that whatever diabetes epidemic that we are seeing in the present decade is a result of faulty diet of the past 2 decades. And what are we doing about children? We are still feeding them the same saturated food, the fast food. We think that children should look more rounded and what we call so-called healthy in inverted commas, and we try to feed them more fat and sweets, which is an absolute no. Imagine what will happen in the next 20 years when these children become adults. Diabetes, which is now about 15 to 18% in the urban population, will become 40% or 50%, which is a very high number. We are already the world capital of diabetes and cardiovascular diseases. So by adopting these lifestyle changes, the preventive measures, a good, healthy, happy lifestyle, reducing the stress in our lives, and when we recognize the risk factors like hypertension or diabetes or high cholesterol levels, take the appropriate treatment and follow the doctor's advice. One problem with the Indians is there is a kind of a inability or unwillingness to accept a diagnosis. When we ask the patient, are you a diabetic? They frequently say, no, I'm not a diabetic, I'm not hypertensive. And then when you check up, everything is haywire. They have dyslipidemia, their HbA1c is 10, and their lipids are sky high, but there is no acknowledgement. So acknowledge that you have that disease. That is the first step. Accept it. adopt lifestyle changes, and whatever doctors give their advice, the preventive advice, the preventive health check advices, strictly follow them for a healthy, a happy, and a long life.
Right. So you did talk about age influencing the likelihood of cardiac arrest in women. So how can different age groups, address their own risks?
Yeah, very important question. We frequently ignore that younger women too have heart disease. In fact, there is one study about pregnant women. We always think that in the reproductive age group, women are healthy in the 20, 30, 35 age group. But one study in the United States found that when patients are screened for heart disease when they become pregnant, only about 50% are completely healthy. That means 1 in 2 women either have a high cholesterol level or high blood pressure, they are prone to thrombosis in the legs, or they have some kind of a risk factor for developing a vascular disease, which is very surprising. So that should create an awareness in the younger women population between the age of 30 to 45 years. And that concept of that till menopause we are completely protected is totally gone. I think we should remove it from our mind. It is misleading, and it leads to less investigations for women. It should equalize, and we should recognize the diseases earlier and treat them. And once they cross that menopause, they become equal to men. So every possible care in terms of diagnosis, in terms of investigations applied, in fact the treatments applied should be equal between men and women. One more surprising thing I would like to tell you is that in even in advanced countries like say United States or Europe, women, especially the colored race women, have lesser access to healthcare, especially cardiac interventional procedures. Less devices have been used, less kind of proper guideline directed therapies have been applied to women. So this discrimination should end once and for all, and we should treat all patients equally, recognize the risk factors at the appropriate time, and apply preventive and therapeutic methods in an equal manner across all age groups. So no age is exempt from heart disease, I would say. Especially if you have a parent or a sibling with heart disease, your risk becomes very high. You get assessed earlier and get yourself treated and apply all the preventive measures to prevent any first vascular event.
So, like you said, there are genetic factors, that contribute to these problems. So, can these be mitigated in some way?
Yeah, genetic factors should be recognized first, especially like I just mentioned, family history is important indicator that there is some genetic happening going on, especially with respect to hypertension, diabetes, heart attacks, dyslipidemia. All these are of polygenic inheritance. That means a group of genes or ones which are causing these problems, and there is a lot of genetic research going on, and I hope in our lifetime or in the next few decades there will be some kind of a gene therapy that will come into play. It has already started with respect to some single gene diseases, but for these polygenic multiple cause things, there is not a therapy that is available, but soon it will be. So once you recognize, there are certain indicators, like for example, early onset of coronary artery disease, or you have a family history whereby your sibling or a cousin or a parent has died at a young age of a sudden cardiac arrest or a sudden cardiac death or hypertrophic cardiomyopathy. So these are all recognized conditions. You have a family history of high blood pressure, both your parents are diabetic and dyslipidemic or have had a stroke. So all these are very high risk factors and indicative of a grouping of genes which are causing these to run in your family. So when you recognize that, you give additional care in terms of repeated checkups, visit to the doctor to have preventive health checks. There are recognizable risk factors which are well recognized and can be treated so to prevent heart disease.
So, are there any advancements in medical technology today that can aid in early detection and prevention of cardiac arrest and cardiac disease in women, especially?
Absolutely. Conventionally, over several decades, there has been a methodical improvement, a steady improvement in diagnostic and whatever that pre-test probability or prediction of coronary artery disease, what we call. So there are conventional things which have been recognized, like we spoke of, like we check the lipid profile, we check the lipid subfractions and try to find out. We do the basic investigations like ECG, echocardiogram, treadmill testing. All these will give an indicator of the vascular health of the individual. But of late, there are very advanced things, like you take the picture of the retina of a patient and see that there is an early atherosclerosis. So this gives a very early alert for us. There is what is called as these, I'm giving just random examples, lipoprotein A in the circulation, which is peculiar to South Asian and Indian population. We check that, we find it high. It has been associated with the occurrence of heart attack and strokes, or combination of these two diseases in younger individuals, which if we recognize and maybe treat, it may reduce these events in the future. We have calcium scoring in the heart. If there is deposition of calcium in the heart vessels and we are able to pick it up early, it is a very strong indicator that these patients may have underlying blockages in the coronary arteries. So all these kind of screening tests are now coming up in a big way, where non-invasively, without applying any invasive methods, we can diagnose and preempt some of the heart attacks and strokes.
Amazing. And are there any specific cultural or societal factors that will impact on awareness and understanding and acceptability of our cardiac health?
Absolutely. We have to understand that these factors, these diseases are common across the globe. As we spoke in the introduction, vascular disease is number one killer in the US, in Europe, in Asia. So it is not an exclusive disease of the rich. There was an earlier concept that in developing nations or underdeveloped or poor nations, it is about infections and hygiene and public sanitation and disorders related to that. But now we have become equal or more. We are becoming world capital of lifestyle diseases, despite being in the developing country or yet to be completely developed. So there are certainly regional and cultural differences with respect to the various disorders, their acceptability. And of course, the most important factor, I would say, is the health economics. Our country, we know that substantial population cannot afford a great quality healthcare, though the government has done its bit to bring down the costs and give a proper healthcare. In terms of diagnostics, there are several cultural, ethnic, and regional and economy driven differences in healthcare.
So, can healthcare providers better tailor their approach to address these women's unique cardiac health problems?
Absolutely. We should tailor their according to the needs of the certain age groups, especially like I mentioned earlier, women should not be discriminated with respect to any test. Like, for example, a few years ago, when we were interviewing cardiologists for a survey, a treadmill test is not prescribed for women for some reason. I do not know. I do not. We do not have a proper policy. So we miss several patients with atypical symptoms. So the healthcare providers should make it uniform to across all the age groups, that detection of this disease, detection of there should be no discrimination of gender or of the age groups, and they should be applied to all sections of the society, made affordable, so that the diagnosis can be early. And of course, the preventive measures also has to be uniformly applied across the population.
Right. So, what role does physical activity actually play in reducing this risk of cardiac arrest? There some recommended exercise routines for them?
Yeah, very important question. Like I mentioned in one of the earlier questions, physical activity plays a very important role in preventing several disorders. In fact, a sedentary lifestyle is very important, as important as smoking. If you sit for 8 to 10 hours in a chair, 6 to 8 hours in a chair, it's equivalent to smoking a pack of cigarettes. So that is the kind of risk we put ourselves to when we follow a sedentary lifestyle. Regular exercise in the terms of a simple habit like walking for 30 to 45 minutes, they say 150 minutes in a week, at least 5 days in a week, if you follow some form of physical activity. Any physical activity is good than no physical activity. Simple walking. If you cannot find time, intermittent walking, some kind of aerobic exercise, will reduce your risk of developing hypertension, high cholesterol levels, diabetes, obesity, heart disease. Everything reduces. Your general fitness improves. Your body mass index is maintained at the correct level. Your obesity levels are controlled. You will attain your ideal body weight, and several benefits are there across the spectrum of this non-communicable diseases. So exercise, regular activity is an extremely important part of the preventive strategy for all these diseases. More mobility, more longevity, that you remember.
And alcohol consumption also contributes to the risk of cardiac women.
Absolutely, absolutely. Consumption of alcohol, even in our conservative society, we think that there are various misconceptions that alcohol protects the heart. It is absolutely no, no. If you speak to any cardiologist, we will strictly say that alcohol is a strict no for all cardiac patients. Even in preventive disease, it has absolutely no role.
So, what steps can workplaces take to promote a healthy heart awareness and to support these female employees?
Oh, very interesting question. Workplaces, especially the modern workplaces, have introduced several measures. If you see the larger companies, they have realized that their staff members are at risk of heart disease, and any event it causes a fear psychosis amongst all the other staff, though. So they have introduced a lot of measures like a relaxed workplace, avoidance of stress, avoiding those kind of time constrained work pattern. The staff is more relaxed, and at workplaces they have now provided exercise rooms, treadmills, gyms, and the healthy food habits have also been included in many of the workplaces, where they have avoided sugar or caffeinated drinks. They provide a healthy diet. On demand, a cardiac diet is available in some of the places like Google or Microsoft or bigger companies or Cognizant. If you go, you can demand and get a good cardiac diet if you want. So all these changes, of course, they have become more conscious. They are the ones who have created chat gpt and artificial intelligence. So now they have realized by applying the same measures that heart disease can be prevented, so they are doing their best. So basically I would say creating an environment which is stress free, conducive to a healthy, happy work style, and also providing some sort of exercise to prevent their sedentary habits. If you see they are hooked to a computer or a laptop day long, if you can give them treadmills or a 10-minute break to walk around or do some kind of activity or sit in a garden or do some cycling, all these factors would certainly impact their health in a positive way.
Right, right, you are. So, we tend to see that women, especially Asian women, those in India, they tend to gain weight near in their mid body, abdomen, the buttocks. And are these women more prone to heart disease, like the PCOD women also have pear-shaped body? Are they more prone to heart disease?
Absolutely. Very important risk factor in our ethnicity, especially in India and Southeast Asians. We see what is called as an abnormal waist to hip ratio. We tend to accumulate our fat in the visceral fat area, especially around the abdomen. And this seems to be an important independent risk factor, independent of other risk factors in producing heart disease and diabetes and what is called as a metabolic syndrome. We people don't have such big body sizes like the westerners, or especially the Americans who are 6 foot 6'5", and their body sizes are big. We tend to be 5.5, 5.8, 5.7 in this range. But when we calculate our waist to hip ratios, these are abnormal, especially in women. And this seems to be a very important risk factor, so we should be conscious of that and try to reduce our saturated fat intake and maintain our body mass index. We recommended body mass index is about 23, and we should stick to try to achieve that. Even if it is not achievable, at least 25. And if we don't calculate the body mass index, which may become normal because of our small body size, we should look at the waist hip ratios and try to maintain it in a proper range.
Very good. You've been talking such good things all throughout that I have not noticed that are time. up. Thank you so much, Dr. Keshav Murthy, for joining us today. Could you show us the certificate, please? This is a small token of thanks for giving us so much knowledge, uh, for to all the listeners and to me also. I've also learned so many new things today. Thank you, Dr. Keshamurthy, again. That will be all for today. Dr. KK Med Talks will return tomorrow at 7 p.m. with another edition of the show. Keep watching Dr. KK Med Talks.
Thank you for the opportunity. It was a great learning opportunity for me too, and I'm so honored to be invited to this forum.
Thank you. I'm humbled. Thank you.